Of state and local government to order. Clerk, please call the roll.
Chairman Wiggum.
Here.
Vice Chair Stevens.
Here.
Ranking Member Kelly.
Here.
Representative Becker.
Here.
Representative Ginter.
Here.
Representative Greenspan.
Here.
Representative Hambley is checked in. Representative Kennedy Kent. Representative Russo.
Here.
Representative Skindell is checked in. Representative Smith.
Here.
Representative Sobecki.
Here.
Representative Strayhorn. Representative Swearingen is checked in. Representative Wilkin.
Here.
Mr. Chairman, the quorum is present.
We have a quorum present, and we'll proceed as a full committee. The next item of business is to approve the minutes from May 27th, the 2020 meeting. So members, those are on your iPads, and you can review those minutes from the previous committee. And with no objections, the minutes will be approved.
That's my mistake. It'll be after 2 seconds.
Do you need a refresh?
It's just loading here. It's just being slow.
Okay.
If they now refresh their iPads, they should be there.
Okay, if you refresh your iPads now, we should have them. Okay, I'm still not seeing them. There we go. Got it. Okay. I'll restate that. They should be up on your iPads now. Okay, with no objections, the minutes will be approved, and hearing none, the minutes are approved. Okay, we are going to start with rearrange our agenda just for a moment. We're going to start with House Bill 624. And before we get, and 624 is report and release certain COVID-19 test information. And this is for its second hearing. And members, at your desk, you should have a printout. This is from Representative Grindell's office. And it is a printout of the answers to the questions from the last meeting that we had. And you should, Dylan, have we sent that to everyone's email too? Okay. We'll make sure that everyone gets it via email also, just so you can check it out. And if there's any other questions that you have, we'll make sure that we have those answered too. Okay, with us today, we'll start off with Jack Windsor, independent investigative reporter with WMFD TV to provide testimony. Mr. Windsor, welcome. Thank you for coming to this committee today, and please, at your pleasure, start.
Chairman Wiggum, Vice Chair Stevens, Ranking Member Kelly, and honorable members of the Ohio House State and Local Government Committee, thank you for allowing me to speak today about why I support House Bill 624. My name is Jack Windsor, and I am an investigative reporter working with WMFD TV in Mansfield, Ohio. On May 28, 2020, Representative Grindell stated in her sponsor testimony, the major problems with the reporting of data concerning COVID-19 by the Ohio Department of Health are that the reporting has been one-sided and woefully incomplete. Only the data that promotes fear and despair, confirmed cases, hospitalizations, deaths, has been reported by the Ohio Department of Health. What has not been publicly reported is the other half of the story. The number of confirmed cases that did not require any medical care, the number of patients who were treated and released from the hospital, the number of individuals who tested negative, the number of deaths that did not involve nursing home residents or prison inmates. a number of individuals with contributing factors such as diabetes, heart disease, high blood pressure, pulmonary issues. Why is this important? Data matters. When stay-at-home orders were issued on March 23rd, Ohioans were charged with flattening the curve and buying time for hospitals to ramp capacity. As we enter our 11th week since the statewide lockout started, many Ohioans still ask, are the hospitals in danger of being overrun? Are we going to see a spike in the curve? And if there is a spike, how bad will it be? Information shared daily by the governor's staff on social media reports the cumulative number of the following: positive cases, hospitalizations, ICU visits, and deaths. Unless mention is made during the governor's press conference, important information such as whether our hospitals are in danger and if the virus outbreak is spiking is not clearly reported and not easily understood. Now, I praise the Ohio Department of Health and Governor DeWine and his staff for their devotion to collecting significant amounts of data. Compared to other states around the country, Ohio has been one of the best at collecting information. Collection and use are different. The true value of accurate and timely data is derived when that data are applied to accurate and timely decisions. Information out of Italy revealed the following critical factors DeWine and Acton could have used to laser focus their response to coronavirus. People aged 79 and older with other diseases are most at risk for serious health outcomes, especially death. More than 75% had high blood pressure, about 35% had diabetes, and a third suffered from heart disease. Information out of Italy and China was also available before the Ohio Department of Health Director, Dr. Amy Acton, signed the first stay-at-home order. The perils of economic fallout and sheltering in place were also documented for consideration as the administration formed policies. After the SARS outbreak, studies on the secondary impact of mental health showed serious distress among those quarantined, causing PTSD and depression when the sick were quarantined for just 2 weeks or less. The 2008 financial crisis spiked suicides due to unemployment. Rates were 4 times higher. A 1% in unemployment resulted in a 1% increase in suicides among males. Instead of using a scalpel to carve out policies to target the most vulnerable, alleviate economic impact, and spare the uninfected from sheltering, Governor DeWine, Dr. Acton, and Lieutenant Governor Husted did the opposite. They swung a wrecking ball. What we know today about COVID-19 we knew in March. Regardless, measures were implemented and then defended by pointing to data and case studies from the Spanish flu epidemic, or pandemic rather, which happened over 100 years earlier. Hospital capacity, ICU capacity, and positive cases never came close to inaccurate projections. The health system we set out to save by flattening the curve has actually been negatively impacted. The broad cancellation of elective procedures, including things like cancer screenings, has led to furloughs, layoffs, and loss of healthcare capacity due to economic consequences of not having enough patients, COVID or otherwise. Plus, there's a broader health consequence to the mental, emotional, and physical outcomes of Ohioans that we are just now beginning to understand. During each press conference, Dr. Acton will review the Ohio COVID-19 dashboard. You may note that Dr. Acton reports deaths, quote, deaths reported in the last 24 hours. Deaths reported in the last 24 hours are different than the actual number of deaths in the last 24 hours. The number reported includes deaths over several days, perhaps sometimes as far back as January. The practice of using reported data causes the public to perceive more cases and more deaths than are occurring at present. The practice is confusing to the press, the public, and at times to the governor and Dr. Acton. For example, on March 23rd, the Ohio Department of Health indicated there were 84 reported deaths over the past 24 hours. However, the real number of deaths, as originally displayed on the CSV file available on coronavirus.ohio.gov, was 7. That number later went up to 9. As of June 1, the number is now 27. But on the day of that number first reported, there was a difference of 77. This information is found by doing some digging and manipulating to the spreadsheet file, the CSV file. Inflated and inaccurate data gets picked up and reported by unsuspecting news outlets. That, in fact, did happen on March 23rd when an Ohio media outlet reported the 84 deaths under the headline, deaths more than double the previous 24-hour period. During a press conference on April 14th, Governor DeWine reportedly claimed 50 people died over the previous 24 hours. The actual number of reported deaths was 5. When confronted with disparity, Governor DeWine deferred to Dr. Acton, who said, "I think it might be a reporting lag." Total deaths includes confirmed cases and suspected cases. Confirmed cases, test confirmed. Suspected doesn't require a confirmed test. Daily, the number prominently displayed and most discussed is total deaths. On June 1, for example, Ohio reported 2,206 deaths. 1,193 of those deaths were confirmed. The difference between total deaths and confirmed deaths is 213, which is a difference of 10%. In March, the original testing methodology was more strict than at present. Early on, a patient had to be sick enough to appeal to the judgment of someone in the health system who judged whether the person was symptomatic enough to get a test, because tests were rationed. Then a test was administered and the result was rendered. The methodology changed, and that change has not been clearly explained, and the data trend lines include these data points. The R0 factor is a number indicating viral infectiousness. The R0 tells you how many people will, on average, be infected by one infected person. For example, if COVID-19 had an R0 of 4, one infected person would, on average, infect 4 other people. One solid step regarding the reporting of information to making R0 more meaningful requires carving out congregate living data sets. Congregate living includes facilities such as nursing homes and prisons. Extracting, measuring, and independently dealing with people who live in these close quarters will produce not only an R0 that more accurately represents community spread, it will also produce policies that save lives in prisons, nursing homes, and long-term care facilities. Mixing congregate living and statistics from the general population skews how infectious the virus may be to the general population. A spike in congregate living settings could equal a clampdown in the general population, and it would be like punishing an entire class for one child acting out. Continuing to report and create policy with mixed data sets breeds misinformation, and frankly, it panics people. Common sense can derive that if the current R0 is 1-to-1 with mixed data sets, the general population is experiencing a contagiousness that is a fraction of the R0 in congregate settings. What may be discovered once the congregate living numbers are backed out is that the R0 is likely significantly lower in our communities than the current 1-to-1 ratio. Understanding the difference between the R0 in congregate settings versus the R0 in our general population should drive more on target mitigation and policy decisions. A few weeks ago, Dr. Acton estimated death rates in nursing homes comprised just over 20% of the Ohio death toll. As reporters and citizen journalists investigated that claim, it was discovered that confirmed deaths were double that estimate. That number was based only on the numbers reported April 15th forward. Further investigation found the percentage to be even higher. Continued digging reveals that as of May 21st, confirmed deaths in nursing homes total 79% of the state total. The errors in reporting and the disproportionate deaths in long-term care facilities seems to stem from mixing the data sets, slow responses, and overall lack of focus on critical information. The state has reported data broken out by senior congregate living and prisons, but did decision makers dig into that data well enough, particularly pertaining to nursing homes, to see the magnitude of the problem? The administration was void of understanding of the total number of deaths from the nursing homes. This seems to signal a lack of tight focus on our senior living facilities. Consequently, was it this lack of focus that drove the less aggressive, non-compulsory tactics that could have been deployed? What if the state had not only segregated the data sets, but taken strong, aggressive, and compulsory action? In the elderly population, the time from COVID-19 onset to death is an estimated 14 days. The nursing home crisis is condensed to less than 1% of our population. Residents in nursing homes are the most immobile in our communities, and they are easily identified and reached. The slow response to directives can best be seen in the delay in the governor's response to a directive from Vice President Mike Pence that called on all governors to perform testing in their long-term care facilities. all nursing home staff and patients. Pence announced that directive on May 12th. On May 19th, a week later, Governor DeWine took steps to ramp testing in nursing homes, saying that he would be deploying the National Guard to aid in testing. However, during his press conference on May 28th, Governor DeWine said that the National Guard would be dispatched to nursing homes this week, the week of June 1. During press conferences from March through May, Dr. Acton has stated the average age of cases. That number was around 50. It dipped to 46 at one point. But has she stated publicly that the median age of death is 81? And if not, why? The fact is, after approximately 5 months of coronavirus circulating in the population, somewhere between 300 and 400 Ohioans, once you extrapolate the data points, have died outside of prisons and nursing homes. As of May 31, 78% of those deaths occurred in people aged 70 and older, 92% of deaths occurring in people aged 60 years of age and older, according to coronavirus.ohio.gov. Nearly a week before the stay-at-home order was issued, Imperial College epidemiologist Neil Ferguson modeled the COVID-19 outbreak. Ferguson's model became the point of reference for leaders across the globe, influencing lockouts and sheltering policies. Ferguson himself backtracked on his model's accuracy weeks after the projections started to tank. The swing and miss on the COVID-19 projection was not Ferguson's first. He predicted 2 million would die from the bird flu in 2005. Those deaths totaled 455. In 2009, Ferguson predicted 65,000 people would die in the UK from swine flu. That death total was 392. Ohio Department of Health Director Dr. Amy Acton delivered early projections and modeling based on Ferguson's wildly inaccurate Imperial College model. Acton guessed that 100,000 Ohioans were already infected when she introduced her modeling. She also projected the COVID outbreak would peak in April, overwhelm hospitals, and unmitigated would produce 62,000 new cases a day and infect 40% to 70% of Ohioans. Like Ferguson's model, Acton's projections were exponentially inaccurate. The Ohio Department of Health model was revised twice, alongside researchers at The Ohio State University. According to an affidavit from Michael S. Wilson, presented in the Rock House Fitness and Others versus Amy Acton and Others, I'm going to read some from that affidavit, and it starts, quote, "The Ohio State model projections dated 3/28/2020 cited a peak of about 10,000 new cases a day on April 25th, with strict social distancing mitigation measures in place. These projections were revised on April 5th to project a peak of about 1,600 new cases a day on April 19th, with the same mitigation measures in place. Both revisions presented a projection for an unmitigated peak of 62,000 cases per day on March 22nd. Actual new cases a day, as reported by the Ohio Department of Health, were below the mitigated projections of the Ohio State model dated April 5th, 2020, for each day between April 5th and April 15th. The model projected a total of 803 new cases on April 5th, yet the actual new cases on that day were 250. Even using the data set available on April 5th that matches the release of the revised Ohio State model, it should have been obvious that the projected model peak would not occur. Mr. Wilson goes on to say, my analysis of the new cases a day utilized at least squares linear regression over the previous 2-week period to determine the growth rate in new cases a day for any given day in the data set. I then calculated a 7-day moving average to determine if the growth rate was increasing or decreasing on a given day. Using the data set available on April 5th, 2020, the 2-week growth rate was barely positive, with a negative trend in the growth rate showing that the growth rate was likely to decrease in the future. This analysis proved accurate, as revised current data shows that the 2-week growth rate reached a minimum on April 5th before increased availability of testing and targeted testing of hotspots caused a secular increase in detected cases that were asymptomatic or less sick than previously detected cases. During a conference call to provide an update on modeling projections that I participated in on April 17th, 2020, Drs. Elizabeth Root and Michael Oglesby of Ohio State admitted that they were not able to exactly quantify the impact of the state enacted mitigation measures and that they had underestimated the impact of social distancing measures taken independently by private individuals. Using similar mathematical methods as described above, the growth rate of new cases a day in Ohio began to decelerate on March 15th, 2020, and began to decline on the 19th of March 2020. Because the deceleration in the growth rate began on 3/15 before the enactment of most state enacted mitigation measures, including the closure of gyms, I conclude that it is not possible to attribute the reduction in new cases a day to these measures. Additionally, the model projections of Ohio State dated March 28th and April 5th are unreliable for determining the impact of mitigation measures through their predictive failures and through the obvious inaccuracy easily determined by an independent data analysis using data available on the day of the April 5th model release and as admitted by its own authors. Therefore, I conclude Director Acton relied upon obviously inaccurate data in creating her mitigation orders while neglecting the impact of private measures to slow the spread of COVID-19. The affidavit indicates that the Ohio State modelers cannot exactly quantify the impact of the state's mitigation efforts. My conversation with Michael Wilson on Sunday, May 31st, uncovered that his modeling not only shows a deceleration beginning in March, it also indicates a maximum peak in cases of 400 a day. These important findings, which may instill hope, have not been shared by the administration with Ohioans. The state coronavirus website still shows an unmitigated curve peak of 62,000 cases a day and a mitigated curve peak of nearly 2,000 cases a day. The information presented to the public, again, seems to be disconnected with real-time updated data. Another important piece of information that has been partially presented is the preliminary injunction issued by Eugene Lucci out of Lake County, Ohio. This injunction came through, again, the Rock House Fitness and others versus Amy Acton and others. In issuing an injunction, Judge Eugene Lucci said this, quote, "The director, Acton, has no statutory authority to close all businesses, including the plaintiff's gyms. She has acted in an impermissibly arbitrary, unreasonable, and oppressive manner without any procedural safeguards." Governor DeWine, when questioned about the ruling at a press conference on May 21st, said, essentially, all the case did was shorten the existing orders by 6 days. Where Dr. Acton erred on projections, Ohioans extended grace because COVID-19 was pitched as a novel virus without clear data on contagiousness, how it spreads, who's at risk, and how many people would need hospital and intensive care. Upfront information did exist, information directly related to COVID-19 and studies related to the secondary impact of the shut it all down policies. The administration has engaged in the practice of intentional selection of data to present to Ohioans. Citizens were promised data transparency and policies based on best science. The results, nearly 1 million unemployed. Somewhere in the ballpark of 1,300 to 1,500 nursing home deaths. A startling number of businesses that will never reopen, and unfortunately, if history repeats, a 16% and counting increase in suicide. Again, as we enter the 11th week since the statewide lockout started, many Ohioans still ask, are hospitals in danger of being overrun? Are we going to see a spike in the curve? And if there is a spike, how bad will it be? We have the answers to these questions. Please support House Bill 624 so Ohioans can finally get the answers to their pressing questions and the promised data transparency that they deserve. Thank you for your time, and I will be happy to answer questions.